So thank you very much for the honor of inviting me to make a presentation at this very august event. And thank you again for the kind introduction. And like has been said, I'm going to talk briefly about the promise and challenge of health systems research. And I've subtitled it, "A Goat That Belongs to the Whole Village Belongs to Nobody." And I'll explain why as I go along. It's a West African proverb. Okay, I'll first start off by asking, what are we talking about when we say we are talking about health systems research, also sometimes called health policy and systems research? And I take the definition from the Alliance Health Policy and Systems Research, which says that basically it's an area of research that seeks to understand and improve how societies organize themselves in achieving collective health goals and how different actors interact in the policy and implementation processes to contribute to outcomes. Now, just by its nature, it's basically interdisciplinary. It draws on several sciences, many of whom are in the social sciences, such as economics, sociology, anthropology, political science, but also public health and epidemiology, to try and understand health systems and how they respond and adapt. Okay, now there are several conceptual frameworks in the literature, but they actually have more commonalities than contrasts. And because for social sciences and health policy, health systems research is predominantly a social science, frameworks are very useful ways of organizing your thinking to be able to describe, to analyze, and to synthesize. So I'll just quickly summarize what is in these frameworks. One difference is whether the framework focuses on the healthcare system versus whether it focuses on the health system. The focus on the healthcare system is where more the focus is on the systems for delivering healthcare to populations and individuals. Whereas when the focus is on the health system, there's a more explicit recognition of the wider socioeconomic and other determinants of health beyond delivering healthcare to populations, so that you are coming more from the paradigm of the WHO 1979 definition of health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And one of the most endearing current contemporary frameworks is the WHO framework, which starts from the definition of what is a health action, and says that a health action is any set of activities whose primary intent is to improve or maintain health. So that then when you are talking of a health system, all the resources, actors, institutions related to this primary action. So, for example, in that report, they give the example of what is the primary action of seatbelt legislation. Even though it's legislation, a lot of it is enforced by driver and vehicle licensing authorities and so on. The primary intent is to save health. So you could think of seatbelt legislation and thinking of the health system. Then all the frameworks have commonalities around goals, around the recognition of the complex and multidimensional nature of systems. It's not always explicitly stated in all frameworks, but it is implicitly there that values, because values are the things that society values, the outcomes of behavior that it values, which then drives the systems and institutions that society set up. Then there are the structures and institutions used to achieve this, or the building blocks, and there are also the processes. So what is emphasized will vary from framework to framework, and I'm not going to spend this morning talking about frameworks. I just mentioned them to create a background for what I'm saying. Then the last thing is, what are the goals of health systems? Because again, it influences what you are researching. All frameworks agree on this defining goal, which is health. and it's the health of individuals through life, and it can be health as measured through fatal outcomes, that is mortality. It can be also health as measured through non-fatal outcomes, morbidity, quality of life, and so on. There are two other goals that sometimes in some frameworks they appear as a goal, in some frameworks they appear as a value, and in some frameworks they appear as both. Responsiveness is basically a social goal. It refers to, the fact that people value how they are treated and the environment in which they are treated when seeking health care, regardless of the outcome. If I can use an example from my work years ago when I used to be a district medical officer in a rural district, and we got to a community one morning and everybody was in black, everybody was somber. What's the problem? Well, the head of the community's son fell into the river that flows through the community and he drowned. And they kind of picked him out alive and they rushed to the nearest hospital, but there was no doctor. They said he said he was burnt out, he was going to play tennis, nobody should call him again, he's had enough for the day. And to find him took time, and the nurses were short-tempered. And the village was in mourning, not only because they had lost a valued member, but they were also in mourning because they felt even though we lost him, if we had been treated in a way that made us feel more human, we would have felt less bad about this incident. So that's an illustration of why responsiveness mattered. Then you have the issues around fairness or equity, and they can be goal and they can be value. So people value, excuse me, equal treatment for equal need and equal treatment for an equal need. If I am disabled and I cannot walk, to create a ramp for me, even though everybody else is using the steps, is an equal treatment. But I do have an unequal need, and it is very fair and very equitable to do that. So that's what equity is about. Then the next thing I'll talk about in trying to understand health systems research is the fact that health systems are complex. They are not just a system, they are complex adaptive systems. Now, all systems have in common the fact that they have separate but interconnected parts. The very simplest illustration I could give is a key and a lock. It's actually a system. There's the key and there's the lock, but they are interconnected. You can only fully appreciate them by appreciating the relationship and the interconnectedness between the parts. And then the value of the connected whole is greater than the value of the sum of the individual parts. So if I only have the key, it really doesn't have the value as when I have both the key and the lock, and I can put it on a door to create the functionality of allowing or denying access through that door. And then complex adaptive systems, beyond being a system, and I've just used a key and a lock as the simplest kind of system to illustrate this, they are adaptive because they are constantly changing. They are governed by feedback. Intervening in one part of the system almost always have ripple effects in other parts of the system. They self-organize and they adapt based on experience. So you have things like path dependence or the history matters. And as an illustration, let's take something like universal health coverage. It's part of the SDGs now, and all the world is struggling to it, but there are some countries which are there already, and I'll just use it to illustrate this path dependence issue. Germany has effectively universal health coverage. People may say they have this problem, but fine, it's effectively universal health coverage. The UK has effectively universal health coverage. South Korea has effectively, and Thailand has it, but the paths by which they have attained it are varied, and some of it is a function of their history and where they are coming from and their context. Then you have feedback loops, so actions in one part of the system go back to affect the system. you have skill-free network, emergent behavior, and so on. Today, I'm not talking about complex adaptive systems, so I'll not use too much of this talk to go into it, but just to draw attention that not only are you researching a system, you are researching a complex adaptive system. And the complex adaptive nature of health systems is very much driven by the centrality of people to health systems. People are there in roles that may overlap as providers, as payers, as financiers, as consumers, as clients, what have you. They are there as individuals, they are there as groups, they have interests, they have power, they have influence, they have ideas, values, and so on. And all this influences how structures and systems are designed, connected, operated from day to day, and ultimately the output. So again, it's very important to keep this in mind when thinking through what kind of research are we doing when we talk about health policy, health systems research. Now, there are varying terminologies in the literature, but so for example, I've talked about structures and institutions. Some will talk about building blocks, about hard subsystems, about critical functions, about hardware. Basically, it's all talking about structure, not the people part. And it can be categorized in various ways as services, as resources, for example, human resources, health workforce, technologies, as information, as finance, as governance. The main thing is all this are talking about structures, not the people part of health systems. Then you have processes that occur within and between these structures. Now, these are moved by people. Actors play a central role in initiating, in shaping, in maintaining, in terminating processes. The same resources can be used in different ways, the same structures in different contexts to yield different outcomes. And it's not possible to make a sharp delineation between processes, structures, institutions, and the actors who initiate and maintain them. But it's still important to recognize these components and trying to understand health systems and what occurs within health systems. Okay. Then the other thing is that health systems occur and operate in a context. By the context, I'm talking about the surroundings within which a system occurs. So I used the example of universal health coverage at the beginning. I said I used 4 countries. Thailand is a middle-income country. South Korea and Germany are high-income countries. They've all attained universal health coverage. The context is different. If you look at Germany, Germany really led the way over 100 years ago, and they evolved down a particular pathway. If you look at the UK, they started, several decades later, they evolved down a particular pathway. You look at Thailand, Thailand started even a few decades more later, they evolved down a particular pathway. If you use my own country, Ghana, we are now struggling with the issues. We are evolving down a particular pathway. And the pathway each country is evolving down is a function of the context of the country, its economics, its politics, its culture, its sociology, and so on. And it all affects the way we evolve. And then the people at the center also affects the way it evolves. So I've kind of illustrated it almost with concentric circles with context outside, but still people, their values, the processes they initiate, the way they use the building block, all coming together to influence the outcomes. And if I can just use a short illustration from my own country, if you take our effort to attain universal health coverage, it's been moved along by the fact that there were user fees introduced, which brought out-of-pocket payments, which were equitable. So they had a huge social outcry that this is not fair. In the context of that, people were ready to try something else. They were ready to, let's give anything which will get us out of this mess. Whereas there are other countries in the sub-region who had declared health services free, and we're still at that stage. At one point, Ghana was at that stage. We moved on with structural adjustment. For them, there's been the struggle of, if this is free already, why do I need to contribute to health insurance? It's so very simplistically, that's an illustration of how context can influence pathways. Now, what is the promise of health systems and health systems research? It holds a huge promise because health systems belong to everybody. If you look at the definition I said at the beginning, I said health systems research is trying to understand and improve how societies organize themselves to achieve collective health goals. So the health systems are really the platform, the framework, the shelter from which societies are doing this organization. They're a common pool resource. All efforts to improve population health or individual health draw on this common pool resource. So that's the promise of this very valuable common pool resource. And another way I find it useful to think about this resource is a shelter for protecting the health of the population, where the systems, the structures are, if you like, a foundation, the values are pillars, and the roof is the programs and intervention, and the context is the ground on which the foundation is laid. So that within this building are all the various things we care about. Is it controlling TB? Is it stopping malaria? Is it dealing with non-communicable diseases? This building has to provide a shelter for the population. It's a common pool resource. Now, there's the promise of a common pool resource is also the challenge of a common pool resource. I've used from West Africa a proverb which has the same idea: a goat that belongs to the whole village belongs to nobody. It's a goat that we've agreed that we as a village, we share in common. If the goat produces milk, the children who need the milk can have it. You know, if the goat produces wool, the person who's cold can have some of that wool, and so on. It's a shared valuable resource. But precisely because none of us individually owns that resource, there's a real danger that we neglect that resource, or we allow self-interest to cause us to try to exploit that resource. So somebody decides to milk the goat all day and not to take it out to feed. You might end up killing that goat. And it's, in fact, Garrett Hardin describes the same problem, you know, in his well-known paper, The Tragedy of the Commons. And I've taken this cartoon from online. I've taken the website which goes with the paper, which uses the illustration of self-interest allowing people to destroy a common pool resource. Okay. How does it play out in health systems? One of the ways it plays out is that though many stakeholders draw on the health system, there's sometimes a hesitance to invest resources in researching or building this system, precisely because of its shared nature. If I invest in strengthening the health information system, how do I claim what's the output of my investment? When I invest in it, anybody who needs information is going to use that excellent system. So who pays for it and who takes the credit for it? So that's the potential tragedy, and it's really a tragedy driven by self-interest, where you maximize your niche at the expense of the whole, and you might end up destroying that valued pool. And it can be particularly acute where resources are limited, such as the poorer countries of the world. So how do we create transformation and increase the recognition that this common pool resource, that this shared resource has to be protected and cared for, even as we draw on it, so that the output is maximum for all of us? I'll give a few suggestions as we come to the end of this, and this is just my thinking for debate and critique to see how do we create a change. The first thing I want to talk about is the fact that we do need advocacy for understanding and valuing what this health system is, what it means to research it, and the fact that it's a finite pool resource and we need to build the resource even as we draw on it. Forums like this one, where we discuss health systems research, is a good way of advocacy. And then also the recognition that when we think we have communicated, we probably need to do it again times 100. And then the other thing is using windows or open by focusing crises such as epidemics and pandemics. In fact, in West Africa, Ebola was a major wake-up call that you need to strengthen your health system. If you had had a stronger health system in the countries where the epidemics at the front line, where the epidemic started, in the remote rural areas of West Africa, so that the system was so weak, it took several weeks to diagnose what was happening. And for such crises, the earlier you diagnose, the quicker you avoid a big crisis. COVID-19 is another example where, again, we wake up to the fact that the finite resource, the health system, matters to protect all of us. The next thing I'll talk about in creating transformations, resources. And resources, capacity is a resource. You need multi-level capacity. Capacity is the ability to perform. And the ability to perform is a function of individual skills. It's also a function of institutional skills and contextual skills. And also the resources you need to perform. So we need to develop multi-level capacity for health systems research, individual, institutional, contextual, and then also look at how do we finance health systems research. Should we agree that whenever we are financing research into improving health outcomes, we look at giving a fraction to looking at how the health system can be better enabled to help us improve these outcomes? Then also recognize self-interest and try and deal with it, both by being critically reflective and reflexive as individuals, regardless of our interests, but also as nations and as funders and as societies, and avoid single interest group capture. And then, difficult as it is, we need to keep finding ways of demonstrating how investments in health systems research are contributing to outcomes at multiple levels, global, national, subnational. There's still a lot of conceptual work needed on this area. I've mentioned how complex health systems are. It can be so difficult to tease out what is making a difference with this investment. The other thing I want to talk about as I draw to a close is to beware of what I call the illusion of low-hanging fruits and quick fixes and short-term investments. The reality is that to protect a common pool resource requires long-term commitments and investments. An example is the earth and climate change. Climate change hasn't occurred because of something we did in 1 year or 2 years or 3 years. It's the culmination of years of behaving a certain way. And to reverse it is going to be the effort of years of behaving another way. It's the same with health systems. And I say it because sometimes there's the impression that there's a quick, a snap way of fixing health systems. There isn't. It can be an illusion. There's a story I read somewhere about a man who was a bit drunk and he lost his keys on the street and he's looking under the street light for it. And a passerby says, "You seem unsteady on your feet. Have you lost something? Can I help you?" He says, "Yes, I've lost my keys and I need to find them." And the passerby stops and says, "But I can't see any keys here. Are you sure this is the place where you lost the keys?" And he says, "Oh, no, I lost them over there in that dark portion of road, but there's no light there. So I'm looking for it here where there's light." And I use this story to illustrate the fact that sometimes that's the illusion of low-hanging fruit and quick fixes. We do need to be ready to tackle this issue over the long term. Thank you so much for your attention and the privilege of talking in this meeting. Thank you.
Thank you, Irene, for this wonderful overview. This is open for discussion. Maybe other questions? Otherwise, maybe I would like to start with a question. So for me, there's a huge important aspect would be the people involved in these health systems. So how much effort does also health systems research is lying on education of people in the health system who have to contribute, essentially contribute to the different parts? Could you hear me?
Yes, I heard you. Thank you. Yes. No, people are really critical, and in fact, part of health systems research is understanding how to reach out to people, how to communicate with people, and how to work with people. And I mentioned briefly about the issue of understanding power, understanding influence, understanding values, and understanding stakeholders and analyzing stakeholders as part of health systems research. That's what I would say in response to this question.
Good morning. Thank you for your talk. I'm a psychologist, and in psychology, we've long found that our behavior is controlled by our consequences to a much larger degree than we think. And it is usually controlled by short-term, deterministic consequences, things that happen right away and more or less certainly. Long-term probabilistic consequences have almost no impact, otherwise we would have no smokers and so on. Getting back to your last remark on low-hanging fruit, and you need a long perspective. I totally agree, but do you have any idea on how we can manage that given our psychological constraints?
Thank you very much. Yeah, that's a really great point. That's true. Our behavior, we do tend to see the short term, and in fact, that's the problem. Why people are tending to look for low-hanging fruits and doing the short-term investment. And I think the answer to this question goes back to the question the first questioner raised, that how do you educate people? And some of it is continued advocacy. Some of it is also, as a health system researcher, recognizing that you have to be in there for the long term and working around the fact that attention spans vary. But you know that you are going to only achieve results in the long term. So as a researcher, despite the fact that maybe attention span is only for a short period, I call them windows of opportunity on this issue. You keep your eye open for the window, you use the window, but you keep working on the issue. If I can use an example from health insurance in Ghana, I said we are still struggling, we are not there yet. I'm part of a team that started research on can you even use health insurance in some form to deal with this problem of inequitable out-of-pocket fees in low and middle-income countries like Ghana? We started in 1992 when Ghana was a low-income country, and we're looking at the non-formal sector, people who are not on any database. We found it so hard to get interest in this question, but we kept working at it and looking for windows of opportunity. And in 2000, it had actually reached the point where the inequities of user fees had now become a national political issue. The election was campaigned on that issue. And when the party that said we will find a way to do health insurance came to power, that was our window of opportunity. And we started presenting our research. This is what we know. This is how we can help you. The window has closed again. People are not terribly interested, but I still research the issue, and I'm still waiting for the next window of opportunity when the attention span. So it's using things like this, but it does require this commitment and this interest in health systems and in the issues, and the recognition that some people have to be in there for the long term, constantly waiting for a way to draw the attention span back. Sorry, a long answer to a simple question, but it wasn't that simple.
Hello, Irene. This is Rainer Sauerborn from Heidelberg. It's indeed a mind-boggling complexity that you showed, and it looks like it's a macro issue which is designed by some individuals like Bismarck or Beveridge, or which is designed by government panels. What is the role of communities? Is there a community level part in co-designing their part of the system, or how did you do it in Ghana? Was this a government level design committee, or was there participation?
Yeah, thank you so much. Yes, yes. No, if I actually, personally, I think community engagement is hugely important. And in fact, I think you cannot get very far if you don't engage the community. In fact, the research we did, I talked about in the 90s through the early 2000s, a lot of it was actually participatory action research, working with the community. In fact, the whole design we arrived at, we did desk review, trying to look at what are other countries doing, how is it working? From the desk review, we then looked at our own context, and then we sat down with the community. In fact, we're working with community representatives from the area councils in the district, from local government, very closely with them, asking at every stage what will work for you, why is it working. Half yearly we were evaluating with them. For one of the things I continue to be sorry about is that in some of the recommendations coming out of our work was that for this to work, you really need to keep that close to community contact. So the Ghana National Health Insurance Scheme actually started with district mutuals, with community governance schemes, but somewhere down the line you had reform which centralized everything. And again, it's all part of the research thing. So sometimes the research and health policy and systems research is tracking these natural changes in policy and politics and the effects it has, and you have to track it over time. So somebody felt this, more community engaged thing is too hard to operate. Let's just centralize everything. So I agree with you. Communities are hugely important, and I would always encourage that you keep looking, researching how to effectively engage them.